Hello, everyone. So my name is Gerhardy, and I am a respiratory physician and ICU advanced trainee and a couple other bits and pieces here at Nepean Hospital, and I'm presenting DDU teaching today. As I was just saying to a couple of people before we start recording, in the past, we've done lots of really good quality sessions that are now up on ISET for everyone to watch with regards to particular pathologies and approaches to things, TOEs and transthoracics and HOCM and diastolic dysfunction and all those sorts of things. So we have a really nice bank of education there, I believe. And I didn't want to reinvent the wheel with some of that sort of stuff. So I thought that today I'd take a slightly different approach. And I've got some cases. Now, we had a series of cases for those of you that have gone through and watched them in the lead up to the most recent DDU Viva exam, so over June and July this year, which were really educational and really enjoyable, I thought. So I've taken that approach again, and I've gone for some cases that are also a bit more unique. And I've done this deliberately because for those of us that are sitting the DDU crit care or other forms of DDU exams, if you are so inclined, then it's also good to expand your playing field, shall we say, and think about doing things like the American Society of Echocardiography board exams, which can tie in quite nicely with studying for the same sort of stuff, and it gives you a more recognized qualification as well. So with that in mind, I've got a very casual presentation here. The idea for this is for it to all be very conversational. It's Friday afternoon after all, and in any other world, we're doing this with alcoholic beverages, but we're not. So this is today's format. So it's conversational. Don't be scared to speak your mind. I will call you out for questions and answers, and there are no wrong answers, just silly questions, I guess. And I take no responsibility for any clinical decisions made based on this presentation. And we're recording, by the way, if I didn't mention that at the start. All right, so this is case number 1. So it's a 36-year-old man. There's his medical background, and he showed our an emergency department. Profoundly hypertensive, facial droop, slow speech, as you can see. And that was his troponin. Now, I'll preface before we get started with the images, because these are all cases that I've taken from online. We haven't retrieved these from our own database here. For some of them, there's only a couple of slides or a couple of cine clips or whatever. So there's certainly not full studies. And I'm doing that deliberately. I'm doing that because that's how it is if you sit the ASE exams, you'll get cine clips like this. And also in the DDU exams, you won't get full cases. You'll get maybe a parasternal along and then a subcostal view or something like that. You can get very limited clips. The idea is just to talk through them. All right, so Chris, would you like to go first? Or Emma, do you want to go first? It's fine. Oh, sorry, there's the case background, okay?
Okay. So 36-year-old man, hypertensive, hyperlipidemia, diabetic, is hypertensive in ED with the left side of facial droop, slurred speech, CT brain's normal, but we're still worried about stroke or some sort of dissection, lots of risk factors now. He's got LVH, a strain pattern on the ECG, and drops up a little bit.
Okay. Only a couple of very short city clips for this one, okay? Actually, only one.
Lovely. So this is a...
What's going on?
Oh, okay.
Yeah. So what for this case, the first case, there's only this clip and then a cardiac MR short sequence.
Goodness, Ben, what are you doing to me here? I mean, so contrast LV of the LV, and what we can see is probably a pseudoaneurysm of the LV. I would worry about that. It looks like there's a defect in the anterolateral wall at the apical level, and then there's with a fairly smallish neck, and then there's contrast extravasating, sort of through that, with what looks like a layer around it, which I'm presuming is pericardium. Putting that together with the history, you'd be worried if there was some thrombus in there and that had flicked off to the,
very nice.
The brain.
So I'll cut now. I wish I had more echo images of this case, but when I saw this, I couldn't not include it to use double negative.
Oh my goodness.
It's cardiac MR. So this is be a series. So it's going to get off axis, but it will loop back through. Okay, and obviously it's a bit sluggish just because the speed of the recording.
You can see the LVH, concentric LVH.
Yeah, nice.
Hypertensive heart disease.
So I'll go back to the start again. So that first image. You can pause it there if you like.
Right.
And you were saying, you can try it. So what do you think of that now?
So I can see what looks like a thrombus sat in there.
Yeah, very nice.
Yeah.
And what do you think of the nature of the outpouching?
The nature, I
You
mean,
were
it looks
saying
more like it
pseudoaneurysm?
looks more like a pseudoaneurysm. And I say that because there's a relatively small neck, but I guess you know, and then the risk of perforation is much higher with pseudoaneurysm. But I mean, it's sometimes hard to tell the difference between them. I definitely want, you know, cardiology to come and help me with this one. But you know, and obviously we need to have someone that knows what they're doing, cardiac MRI, look at it as well. But I'd be concerned about, you know, the fact that it looks like the pericardium is the thing that's just containing it. So it's almost, a pseudoaneurysm is almost like a contained rupture.
Yeah.
And you can see that there's obviously going to be stasis of blood there and some thrombus formation. I think I'm not good with cardiac MRI.
Fair enough. Okay, now this was a pathology that I'd never heard of, and I had heard of pseudoaneurysm and aneurysm before.
I'm quite impressed that a patient presenting with that has already had a contrast echo and a cardiac MRI.
Exactly right. It doesn't fit. Like you'd kind of think they'd presented with, you know, with an MI 2-3 days ago and then developed that.
I'm surprised they're alive, right? So this leads on to LV outpouchings. Now, as Emma beautifully described, you know, you can have an aneurysm or a pseudoaneurysm. Aneurysm has thinned myocardium, but there's myocardium there, sort of broad neck classically, and a low rupture risk. And it's hypokinetic or contracted synchronously with the left ventricle, commonly seen in post-ischemic events and things. Contrasted that with a pseudoaneurysm, that narrow neck, and I consider these the same way that you mentioned them, Emma, which is as a effectively a rupture of the left ventricle that just hasn't led to disaster yet. That's how I perceive it in my mind. This is actually what they define surgically as a left ventricular diverticulum. So there's the full thickness of the myocardium in that outpouching, which you can't clearly appreciate. And it does have a narrow neck, and it contracts synchronously with the left ventricle. Quite rare, but there's muscle there that will contract. Wow. I know, amazing, right? So just as a quick refresher, so this is an old image, but one that I guess a lot of us may have learned or come across. True aneurysm versus pseudoaneurysm. You know, there's the myocardium there versus not for the pseudoaneurysm, which is what contributes to that rupture and mortality risk. There's some literature out there that disagrees with this approach to the aneurysm, pseudoaneurysm. There's format for it, but that certainly seems to be the minority from what I can see. This is the general classification that most of these go into. But yeah, in this young man, when they took him to surgery, which I may or may not have, oh no, I've got some pictures here. So this is a true aneurysm here. So very broad neck in these sort of series of cineclips. It's not really contracting at all. It's just stasis. It's a collection of true aneurysms. And then I think I've got a surgical picture, or this was the best pseudoaneurysm picture I could see. Look at this tiny narrow neck, very thin. But when they took this patient to surgery, yeah, there was the whole myocardial wall there. And they called it a left ventricular diverticulum. Cool pathology.
Are these diverticularly related to hypertensive heart disease, or
not that I could find? From when I looked, I didn't see evidence of that in the literature that I came across. I just saw a lot of stuff saying very rare, and I guess anything that's very rare is not going to be well described from a pathology point of view. All right, Chris, do you want to do this one? Case 2. So 25-year-old female, pleurisy, postural palpitations, that's why she came to ED. A background there of something that's a bit more in my everyday practice, so to speak, some vasculitis, pulmonary hemorrhage, polyangiitis. And this. So what do you see here? It's not the greatest picture.
Yeah, so this is a apical 4-chamber transthoracic view. It's not quite fully aligned in that you're getting dropout of the left atrium, but based on what I can see here, the LV systolic function appears to be preserved for relatively preserved for someone of her age, I would imagine. and the right ventricle is not especially dilated. It looks to be, again, a reasonable size, and is contracting pretty well. The right atrium doesn't look especially dilated. There is a bit of dropout of the anterolateral wall of the LV, but I would like to just look at that with other images. And the septum does appear slightly bright, but I don't know what to make of that on just one image alone.
What the hell is in the right atrium? What's that?
Oh, Emma's
Bouncing
spoken
around?
up. What have you said, Emma?
This structure that's bouncing around, and there's something dodgy about the intra-atrial septum, I think, in this structure within the right atrium.
All right, so progress to the next.
Oh, yeah.
What do you think of this now, Chris?
So you can see that there's a big defect in the interatrial septum, and you can see that with the agitated saline, there's dropout of the contrast, which is suggesting a predominant left to right shunt through that.
Anything else? Anything else?
I mean, is that an aneurysmal intratracheal septum? So I mean,
Yeah.
so the left-sided pressures are greater than the right, obviously. So you're getting clear demarcation. When the contrast isn't there, you do get a suggestion of it's almost like a thumb-like protrusion. That's the area of the intratracheal septum. So
and
whether
you
or
can
not
see
it's
the wall actually of the intratracheal septum, can't you?
yeah.
Yeah.
So this would be a
Is this another of those windsock looking deformities?
Yeah, I guess it is a bit like the windsock. Hey?
Yeah, but it doesn't look like it's the classic type.
Yeah, very nice, Jamal. Yeah, nice one, Chris. I think let's go through here. So they took this patient for a TOE. So you can see it nicely here. Jamal, you said you're a anesthetist or cardiac anesthetist or a bit of both?
cardiac anesthetist, yeah.
You must have passed a bajillion toe probes by now. So what view is this?
It's hard to tell from the Omni, but I mean, they're using biplane, obviously. So it's a 3D capable probe. It's got orthogonal view. Intratracheal septum's either going to be 0, 60, or 120, whichever one you find it best at. This looks like it's probably going to be 60. So 60 on the left with orthogonal on the right. Depends on, it's a bit unclear about whether or not you want 15 millimeters of full excursion or 15 millimeters in one direction or the other. But this would meet either criteria in terms of being aneurysmal. And then you'd want to interrogate it pretty extensively for a PFO because obviously they're quite related. So
very nice, very nice. All right, let me cut through. So they did bubbles, of course, which doesn't tell us anything we didn't already know. And yeah, so as you mentioned there in the diagnostic criteria, 15 millimeters of movement, and so is sort of what they look at, and whether you classify that in bidirectional, so moving from one side to the other, a total width of 15 millimeters, or just from the midline to the other. They say from the midline to one side at least 10, and you should potentially get 15 millimeters there. There's a classification system which I didn't realize up until very recently, and they're not uncommon really, given how many scans everyone does. 1 to 2% of the population, and if you find it on its own, we don't really know what that means, but it's often associated with other things. I mean, atrial septal defect or a PFO is the logical one it's going to be associated with, but there are population studies that suggest it's associated with other pathologies as well. I found this quite interesting when I was looking. So this is, here's a nice fixed interatrial septum from left to right, but our transthoracics are pretty poor at catching them. I guess if you think about it from an anatomical point of view and how well we can see the interatrial septum, it's not surprising. But I guess if you're thinking an incidence of 1 to 2% of the population and you miss half of them on a transthoracic, I guess if we do more toes, we'll find more. I suspect you've seen quite a few in that context then, Jamal. But again, if you find it in isolation, who knows what it means. And then this is the classification system. And now I've not seen this used, I've only seen it in the textbooks. So you can have a right or a left or a right left. Yeah, I think that's all a bit cardiology academic fancy, and certainly not something I'll commit to memory. But the idea is for type 1 and type 2, it only goes from midline to one side. Type 3 and type 4, it's predominantly on one side, it flicks back to the other in type 5, but it just moves side to side quite freely. Obviously, it's all going to be driven by pressures within the intracardiac chambers. What's this one? I've forgotten. Case 3, 6-year-old male, presents to a PH, pulmonary hypertension clinic, progressive breathlessness. He's got lots of reasons to have pulmonary hypertension there with his obesity, I would say.
I was going to say you should get them to read it out because that's what they do in the exam.
Yeah, good point.
Get you to read it in the exam.
Yeah. All right. Jamal, do you want to do this one?
I was
Sure,
just in the Viva exam for the DDU, you will be the one reading it to the examiners, so you might as well just get into the swing of doing that.
Yeah.
All right, so the case is a 60-year-old male who presents to the pulmonary hypertension clinic with progressive breathlessness, of a background of HIV, latent tuberculosis, hypertension, obesity, and obstructive sleep apnea. And they have normal lung function testing and normal lung imaging. Okay, so this loop is a subcostal, ideally 4-chamber, but we're getting more of the atria than the ventricles. This is a subcostal 4. The clearest things, I mean, you could at least say basally there appears to be reasonable biventricular function. The atria without measuring do appear large. There appears to be, and it might just be a function of the imaging because there is some artifact, there appears to be a defect in the intraatrial septum, but that could definitely be an artifact. There's an artifact distal to that, so you want to interrogate it further. Anything else that is visible? Both the mitral valve and tricuspid valve apparatus appear normal, so there doesn't appear to be, at least in this singular image, any flail from either the mitral or the tricuspid. That's about all I would say from this view alone.
Given that the patient's got normal lungs and they've shown to a pulmonary hypertension clinic, do you think is it true atrial septal defect, or do you think it's artifact?
Oh, well.
And given the relative size of the atria?
Well, I mean, if there was that degree of defect, the patient's 60 years of age, they'd have by the look of the motion, they'd probably have a right to left shunting and hypoxia. So it's unlikely to be true, but definitely in some loops, it looks abnormal. All right, so there seems to be color flow across this now. So now we've got color compare mode on the subcostal 4-chamber, focusing on the intraatrial septum. As I said, there may or may not be a defect, or it may be artifact. And so what we've done on the color compare is to place color across the area of interest with quite a reasonable Nyquist. So it's a reasonable setting, but there does appear to be bidirectional flow across that potential intraatrial septal defect. So it's becoming more likely now that this patient does have a true anatomical defect.
Yeah, I mean, I think that this is very interesting because of how high the Nyquist is, right? If you're looking for slower flow, you turn it down, as we often do in intraatrial septums, but you can see it quite clear there at the higher flow.
Jamal, just without the toe image, what type of ASD would you put your money on for that one? What type of ASD and why?
That's rough, but fair. No, it's completely fair.
You still there, Jamal?
Yeah.
No. Or perhaps
sorry, I was muted. I guess a secundum.
Why do you say that?
Well, I mean, this is not the image that you'd see. Well, there's 4 different types. There's secundum, primum, coronary sinus, and sinus venosus. Primum is probably the common. Secundum is probably the commonest. This doesn't look like the position for primum, nor does it look like the kind of appearance I'd expect of the other 2. So coronary sinus or sinus venosus.
Yeah, very good. And secundum is definitely the most common. Yeah, 80%. And got another slide about that in a second. So again, that doesn't. Does that change whether you think it's a primum or secundum?
Not this view, no. Well, I mean, again, it probably puts me more likely to be secundum than primum.
And now, as a cardiac anaesthetist, You're the perfect person to answer this question. What's going on here?
They're probably sizing the defect. So this is toe. So this is, as I said before, intraatrial septum interrogation is usually at 0, 60, or 120. The omniplane here is set to 60, which means it's toe. And what we're seeing there is a giant abnormality in the middle of the screen. And what that most likely would be, in my experience, is attempting to size the size of the intraatrial septal defect, which allows them to determine how big a device they want to place across it. A lot of this would have been done in the planning sizes, because there are some contraindications to attempting to close this percutaneously with a device such as shelves and size. But I haven't seen this one specifically, but I presume this is a sizing device for percutaneous closure.
Yeah, lovely, lovely. That's exactly what it is. They're sizing it. And you mentioned percutaneous closure, and you said by shelves. I'm assuming you mean like the rim of tissue around it for appropriate.
Yeah, they need to have an appropriate rim of tissue to ensure that the device will kind of latch onto it, and the devices only go to a certain size. So if the defect is too big for even the largest device, it will have to be closed, by the surgeons.
Yeah, and that's actually this. So this is the largest sizing device that there is, and as you can see, there's still leak around around the sizing device. So this case had to end up going for a surgical closure rather than a percutaneous closure.
I guess the other questions that you might get asked if there's loops like this wouldn't be something as simple as what type of ASD it is. It might be what are the associated defects with this particular ASD.
Absolutely.
Have you got pictures?
I don't. Let's find out. So types of ASD. So you've ran through those already. But yeah, I think my next slide might give it all away. So there are some associations with particular other cardiac abnormalities associated with particular types of ASDs. Are you familiar with any of those?
I usually remember them closer to the time than I need to remember them.
Yeah, exactly.
Yeah, I think that's appropriate. So I guess the secundum, which is the most common, is associated with cleft mitral valve.
No.
Or is the
mitral valve prolapse?
Yeah. And the ASD is associated with the cleft mitral valve. They're the main ones.
And it's whether you have a partial or complete primum, because complete primum is basically an AVSD.
AVSD, yeah. So we ran through the 4 types of ASD. So this will come up in one of your exams for DDU, either written or viva, almost certainly. And this is easy marks to get. There's 4, and I've got one in brackets there because some resources say complete absence of the atrial septum is a separate entity itself. Note, Mohammed, I'm not sure where you are in your DDU time and study. And Chris, obviously I know you're quite experienced. So PFO is not an ASD, very clearly not an ASD. So don't get that mixed up in there. And there's just the picture of where they all sit, and you nailed it before, Jamal. That's where they all sit. So ostium primum, right up against where that the cushion is, secundum right in the middle, and then the venosus and the coronary sinus. There's an ISET, there's a lecture up on ISET already that Benny Samadi has done talking about ASDs, going through the embryology of it. And she's done it a couple of times. It's amazing. She's very good at explaining it. And there's no way in the world I'd even try and come close to doing it the way she does. I don't know.
Yeah. What the sinus venosus, does anyone know the defects associated with those? And it does become important. They are super rare, these, right? But if we find them, we do
have anomalous pulmonary venous drainage. Yeah. Is that the one with the scimitar syndrome and the other one that I forget?
Yeah, exactly.
And the wait, I always get this wrong. The inferior is commoner than the superior?
No, I think SVC type's more common.
Okay, so SVC is common than IVC.
I think so, but to maybe just double check that. don't believe it just on me saying. And then coronary sinus, what's that tend to be associated with? Unroofed coronary sinus. That should be.
Coronary sinus is normal. An unroofed coronary sinus is the defect. Yeah.
Left upper.
Like a persistent left SVC.
Yes.
I think so.
Yeah.
And I think the most common type, anomalous pulmonary venous return for the sinus venosus is the right upper, I think. Anyway, these are all things to look up closer to the exam. They definitely come up in like the American exam.
Yeah.
And they actually came up in our DDU written as well, didn't they?
This is one of the questions, wasn't it?
Yeah, this is one of the questions.
I think,
so it's worth looking over.
And for the record, this is a cleft mitral valve. So this is not something I've ever seen, and something that I've read various descriptions of. And so I actually went hunting for pictures. And so it is truly just a cleft. And I think this 3D image shows it the nicest. So anterior leaflet at the top of the screen, and it's just a defect in the valve cuspis. Have you ever seen one else?
I've never seen one, but during the ASE course, one of the presenters talk about it looks like it's been snipped with a pair of scissors.
Yeah,
which is how I remember
exactly.
it.
Well, that's what it is, right? Yeah. And you can pick it up on 2D as well. All right, Mohammed, do you want to have a go?
Yeah, I can try. I'm extremely early on.
That's completely
journey, just so
fine,
you know.
because there's plenty of people around that will help.
All right. Just describe what I see.
Oh, you see, yeah, that's what I do.
Transthoracic.
Nice.
Echo, parasternal long axis.
Yeah.
Good view of the LV.
Yeah.
Reasonable view of the LA, but not too open, and a good view of the two valves on the left side. The two valves. Sorry?
What valves?
The aortic and the mitral.
Yeah, nice.
Both valves are opening well.
Yeah.
There seems to be reasonable LV function. The wall doesn't seem too thick. The RV at the top seems like it's contracting, although I can't really assess it properly. It doesn't seem to be an effusion around the LV. Nothing really around the RV on this view either.
Yep. So just getting my computer charger.
Heart rate's quite slow. If it's true, it's 34.
I mean, that might be true. All right, and do you know the left ventricular walls? If not, that's okay, because you can ask for help.
I'd have to ask for help.
All right, Chris, what walls of the LV can you see?
The anterior septal and the infralateral walls.
Yeah, nice. Okay. Now, has anyone seen any other pathology on this screen? Something you could easily miss.
Like a band in the RV. I'm not sure if that's something else, or the obturator, or something in the RV. I don't know.
So I'll move on. I agree. I think you said
there's an anechoic stripe superior to the RV free wall that's a little bit unusual.
Up there. Yeah. There could be some fat up there. Which cavity?
The LV cavity.
Can't get anything past you. All right. So now, what's this view, Mohammed? What are you seeing here? It's the same view, so
it's a closer a closer inspection of the aortic valve.
Yeah, nice.
You can see some AR.
Yeah, nice. What would describe the AR? Is it central, eccentric, small, large?
It looks mild and central in nature.
Yeah, right. And you can see the aorta extending off to the sector there, like extending out to the side of the sector. Does the aorta look particularly dilated, aneurysmal, abnormal? Or does the aorta look okay?
If each dot is a centimeter, then it's about 4-ish, which is sort of borderline, if I remember correctly.
Do slow it down to measure.
And then there's this
cardiac cycle.
Maybe an aneurysm at the top. I mean, I don't think anything at the sector is abnormal, but right in the center of the screen, there seems to be some sort of
up here.
Yeah.
No, I think what we're catching there is we're catching some of the right ventricular outflow tract and just some color through that. I'm not sure what the pulmonary valve is like.
Oh, right. Okay.
Yeah, and that's what it will be. All right. So this is a very poor quality image, but not much to see there. So this is a parasternal short axis focused over the aortic valve to try and get more information, given that there was AR that we could see. And because the image quality was crap, cut to a toe. Have you done much toe or seen much toe, Mohammed?
I've done a bit.
Yeah, okay. What do you see here?
So this would be a 3-chamber mid-esophageal view.
Nice, good.
And you can see the mitral valve on the
Yeah.
left of the screen, aortic valve of the aorta.
Yeah.
On the right of the screen, LV below.
Yeah, nice.
The RV as well. And on the what looks like is that the I don't know what the walls are exactly. I know that at 90, the right would be the anterior, left would be posterior. Is that right?
Of the LV.
Yeah. So therefore, that leaflet would be the.
I see. Okay, yeah.
Of the aortic. Sorry, I'm trying to figure out what leaflet of the aortic valve is to the left.
Oh, what cusp you're seeing?
Yeah, so Mohammed, when you're at the 120 angle, it's a little bit like you're in your apical, your apical 3 chamber. So this one is going to be the anteroseptum, and this one the infralateral.
Right. Okay.
And we see A2 and P2.
A2 and P2. Okay.
Yeah.
We can go through ahead of the time.
Yeah.
You may not have the normal number or orientation of leaflets.
True, but generally speaking, it's not always, as Jamal's saying, there's always going to be variation. We're not even exactly at 120.
Oh, I meant his aortic.
Jamal, very nice.
Oh, what's that? Sorry.
You're saying there might be the appropriate number or orientation of aortic valve leaflets.
Oh,
yeah, the opening looks funny, doesn't it? It doesn't look like it's opening cleanly.
Exactly. It looks like eccentric closure.
Yeah.
Yeah.
So. What do you think's going on? So first of all, Mohammed, how many leaflets does an aortic valve normally have? Not a trick question.
3.
Yeah, and on this image, can you name them or identify them anatomically speaking?
So the one to the top right. No, so the one to the bottom would be the right coronary.
Mm-hmm.
The one to the top right would be the left, and the one to the top left is meant to be the non-coronary.
Yeah.
I might have got. Is that right?
Yeah. So the way I remember it is the interatrial septum is always the non-coronary.
Right.
Assuming you have a tri-leaflet aortic valve. And Jamal's looking at the screen smiling.
I know Jamal knows the aortic valve
better than any of us.
classification better than anyone, because he taught us about the Sievers classification. Was that you, Jamal? It was about
Sounds like something I'd do.
about a year or two ago, actually. And you were telling us about the Sievers classification. It was about 2 years ago, I think.
There's something funky going on with that non-coronary cusp, perhaps.
Well, I mean,
is it?
I think the right, where you would expect the right is kind of interesting, because to my eye, it looks like between the right and the non, whether or not there's another cusp.
Yeah, lovely.
Exactly.
Yeah, lovely. It is.
It's this little one here between the non and the right.
It's like a little nubbins in there, isn't it? You can see where the right and the left abut, that seems normal, where the non and the left abut, that seems normal, but where the left and the where the non and the right abut, there's the appearance of an extra piece of tissue or something in there. And exactly as you said, Jamal, this is a quadricuspid aortic valve.
It's not the prettiest quadricuspid, is it?
No, it's not.
It's not like a 4-leaf clover.
No, but that leads into this, and this is the different anatomical array of them. You can have 4 equal sized cusps, or you can have any of countless number of variations there. So what this guy had, whether he had I don't know. I don't think it matters. Well, it doesn't. I know for sure it doesn't matter. Either way, he did not have 4 equal sized cusps, and he had a quadricuspid aortic valve, which is very, very rare. And so 0.0003%. There is deliberately 3 zeros there, increased by a factor of 20 in translating echocardiographic series. And the most apparently, and Jamal, you can probably correct me if I'm wrong here, because you may very well have seen these before. But from my understanding, typically pure regurgitation is the primary pathology. You can get mixed valvular disease, but normal ARS is the most common. And when they attempt to repair it, they try a procedure called tricuspidization, allegedly. They just manage them otherwise as they are. Yeah, no. I'd love to see some of this stuff on there.
Oh, I thought we had one.
Yeah. Yeah. All right, Emma, back to you.
45 exertional breathlessness.
I remember what this is. Oh, I remember what this is. This is a great one as well. I feel like having Jamal here, he'll have seen all these things in tow. So like we're at a disadvantage, even though I made the presentation.
Okay, so normal left ventricular size doesn't look hypertrophy. The systolic function looks normal. The exertional breathlessness is making me think about, you know, there's either some diastolic dysfunction, pulmonary hypertension, maybe the RV, we can see a little bit of the RV wall that's, you know, sort of maybe looking a bit hypertrophy, maybe the RVOT, you know, thickening isn't quite as normal, but it doesn't look too enlarged. But yeah, maybe the annulus movement isn't that great on this parasternal lung. So I definitely, the LA doesn't look dilated.
The mitral annulus movement, sorry.
Yeah, it doesn't look, you know, completely normal. Maybe there's some B lines we can see. The LA is not doesn't look dilated. We need to see that in more views. So nothing diagnostic on this
Nice.
parasternal lung, unless I'm missing something big, which is possible.
All right.
Yeah, okay. So I mean, there was maybe a little bit of septal bounce on that last one, and we can see that in this one. The mitral valve's interesting. It almost looks like it's a parachute mitral valve, is it? But it looks like it's not a clip, it's in the middle, and it's not obviously. I need to look at that mitral valve more.
Yeah.
But whatever it is happening with that mitral valve, it's seeming to have effect on the pulmonary circulation. I think the RV looks big. There's a little bit of septal flattening, and I think there's probably that's probably the cause of it.
Yeah, I agree. I think the RV was dilated back on that parasternal long axis view.
Has this woman ever had heart surgery before?
No, but very good question.
Like whether they've repaired it. It doesn't look like
an Alfieri stitch.
Like an Alfieri stitch, yeah.
No, good question. I think I've got one with colour over it.
So it's not an Alfieri stitch.
No. And so an Alfieri stitch is for basically they, again, Jamal, you can correct me if I'm wrong here, they throw a stitch through A2 and P2 typically to effectively do a surgical version of really a mitral clip to stop significant mitral regurgitation. I don't know how often it's done. Is that the layman's, cheats way of?
Yeah, look, the Alfieri is kind of a get out of jail. If they've attempted to repair it and it hasn't repaired, then we need to get out of there. Or it's used as more kind of palliative. It was kind of the Alfieri was obviously the predecessor to these edge-to-edge repairs. But yeah, as you say, if this woman has not had an Alfieri, she has a double orifice mitral valve.
Yeah, nice. Exactly. And then so he's got it here in her apical four chamber. Again, I don't think there's a whole lot there. I would definitely say the mitral valve doesn't look normal in this view, but I'd find it hard to describe.
Oh, you wouldn't pick it on that. And how rare is a double orifice mitral valve?
I might be able to tell you, actually. Give me a second. I think I've got the numbers there. So there's there again, not enlightening. Here you go. The double orifice mitral valve. So it can be congenital or acquired. Congenital is often associated with other abnormalities, but they're very rare to start with. So most of the time you have a large jet and a small jet. Rarely you have both. And you can have complete duplication of the entire mitral valve apparatus where you have two of everything. And I've horribly misspelled the word annulus there. And yeah, I couldn't find any images of that, but I thought that was very cool. Incidence of 0.01%, and it may not be found, may be asymptomatic. I know. What do you do? 1,000?
More than I thought, actually.
10,000 echoes, you should see.
Wow. Okay.
And you just major as per heart failure. This is a picture of it. So that's an Alfieri stitch or Alfieri stitch down there. Just one of the Netta style images of what they're doing. I think it's almost 3 o'clock, but my last couple of cases. Chris, this one's for you, especially after, actually, this is perfect timing after you're talking about what your echo boards were like, the BSc exams.
Did you get that? Did you get the thing? Did you get to read it?
Oh, no, sorry, Chris, here you go. Happy with the stem, Chris?
NESB, what does that stand for?
Oh, sorry, non-English speaking background.
All right, it's a nice Australian acronym coming in there.
Oh, we have many.
Yeah, I've noticed. Okay, fine. So 22-year-old recent migration, shocks with recurrent viral respiratory illness, history of a murmur, but clearly no other past medical history that we know of.
Yeah. All right.
Trying to figure out what view this even is. I mean, this is a transthoracic view, which is I'm not even sure what we're looking at here. I mean, there's a valve in the middle that looks like it's got pretty prominent papillary muscles, and what looks like a dilated atrium associated with that. But I'd probably want to be looking at this patient with more than just one view. I'd probably want to be starting from the approach of a congenital scan, where I'm confirming situs first, confirming the connection of all the atria and the ventricles, because if I've just put the probe on and I've got this, I have no idea what I'm looking at.
Yeah, I mean, it's clearly a congenital defect, right?
Yeah.
Presumably unrepaired congenital defect.
Yeah, absolutely.
And I think that sentence you just said of taking a congenital approach of looking for situs and looking for line and then looking for connections and running through in a really structured way. So I can't imagine a unrepaired congenital case apart from maybe congenital AS or something rather than that.
Well, it could be LTGH.
Yeah, no, I was just thinking of in terms of the DDU exams. I can't imagine ever getting an adult unrepaired congenital case in a DDU exam. But for the American board, there were certainly a lot of clips in my setting of them, which was this year, that were like this, where you get a few images. And sorry, Jamal, you said it could be.
Well, I mean, the easiest way to clarify this would be just to look at the great vessels, but LTGH versus was it DTGH? I mean, there's only one that you can live with. So, and he's 25, so there's only one version of transposition that he could be alive with.
Yeah, nearly corrected. Is all that is compatible with life. And so I think that this case, I won't run through, I just thought it was kind of interesting and a bit of a novelty at the end. So they had this down, this is labeled as mitral atresia. And so the only way I could put this together, and please someone jump out at me, is I think that this is just mitral atresia with hypoplastic left heart as a result. And so what we're seeing now are right heart structures, because I can't piece it together otherwise. So it's a short axis here. So whether this is the left ventricle and right ventricle, left ventricle here, right ventricle there. And there's obviously going to be interchamber shunts to facilitate life in this patient, because it's a pretty messed up ventricle. And then just the color images. So then clearly very severe regurgitation of something into something. And so, yeah, so from what I could piece together from the information that was there associated with this case, I think this patient has mitral atresia. I do not know about whether they had aortic atresia or not. So I think we're all seeing just all right heart structures there. And I think the last thing I've got is this. This is my last slide. So I got this slide from my wife, who does fetal scans. Jamal, it's back to you. As an adult, presumably adult cardiac anaesthetist, what are you looking at here, do you think? And obviously this is just pure for fun.
Yeah, I'm just trying to orient myself to this fetal scan and just see what's going on. I guess Yeah. Oh, wait, actually, no, I don't even know what I'm looking at here.
So can you see my cursor? I think you can maybe.
Yeah, I can see your cursor now. Yep.
So this is a ventricle.
Yes.
And then, so what are these?
And there'll be atria. Oh, well, no, they'd be great. They're probably going to be great.
Great
Atria.
Yeah, great vessels.
Yeah. Well, I mean, that appearance and given its fetal scan, I don't know, is it tetralogy?
Double outlet right ventricle.
Oh, okay. Okay.
Yeah. So I mean, I think you can, if you know that that's a ventricle and you can see two structures feeding into or taking blood out of that ventricle, so it's either two atria going into a ventricle or it's two vessels coming out of a ventricle. You can't make any comments at all about the interatrial septum because that doesn't exist in a fetus mostly. You know, there's obviously meant to be a hole there. And then what you can see in the power color Doppler side on the right is you can see the two sets of outflow coming out and looping across, and then one of them is going off the pulmonary circulation and one of them's going off to the systemic circulation as well. Yes, a double outlet ventricle. And I thought I'd finish on this one just because it's something that we'll never see otherwise, thankfully, because who the hell knows what this actually is.
Wow, Ben, that really was surprise cases. Thank you very much.
That's right.
Yeah, it's good to have a bit of pub quiz style echo, quizzes sometimes.
Yeah, I think it's
I definitely learned.
We all see the common stuff, and we can all find some of the uncommon stuff, and it's great for exams, but also every now and then something like this might sneak up in there, right? And so you got to just be able to go back to principles. What to do with
It's nice to compile them all together, isn't it?
Yeah.
Thank you, Ben.
All right.
Thanks very much.
Stop screen sharing there. Done. All right. Thanks for playing, everyone.
Thanks for.
Thank
you. Bye.
See ya. Thank you.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.